Well, hello and welcome to another edition of Health Solutions with Sean and Janet Needham, where Team Needham discusses everything healthcare. I am your host, Sean Needham, along with my wife, Janet, and our wonderful producer, Lindsay. We are streaming live from an underground bunker at an undisclosed location. No, just kidding. We are actually from Moses. We are streaming in Moses Lake, Washington. And we have Dr. James Tinsley on today. He is actually in all the way across the country in Virginia. And I would like to welcome him. He is a direct primary care doctor. We've had a lot of these on lately, and super excited to have him on because one thing is you'll notice one of the reasons we keep having direct primary care doctors on is not just to promote direct primary care, but the realization that every one of them does something unique, and that is what is great, and that is what we like in a free market. We talk about free market healthcare here a lot. I write about it in my book. I think that's one of the solutions to our healthcare pricing issues and overpricing and slow service is actually a free market in healthcare. I wrote a book about it. It's called Sickened, How the Government Ruined Healthcare and How to Fix It. It is available on Amazon. Download it, Kindle version. I'm working on a paperback version as we speak. Going to be done by the end of the year for sure. Also an audiobook version for those people that are driving down the road and want to listen to it in audio form. So yeah, check it out on Amazon. And one of the fixes in there is direct primary care, that consumers use direct primary care and free market solutions to make their healthcare better service and less expensive. So welcome, Dr. James Tinsley, to our podcast.
Oh, thank you so much. I appreciate it. Thanks for having me.
Yeah. So tell us a little bit of story. Your story is pretty common when it comes to DPC doctors and why you got out of the system. I had a doctor on a few weeks ago, and basically he realized in order to change the system, he had to get out of the system. And that's kind of right.
Yeah.
And that's kind of what you did. So tell us a little bit about your history, when you went into medical school and how many places you've worked and all that history and that sad Father's Day when you were never home and your daughter said something to you. So tell us that story.
Oh God, yeah, it was horrible. That was the worst day, one of the worst days of my life. But so look, I went to medical school late. I had to save up money and follow my dream. I didn't have money for college, so I was in the Army for a little while and got out, went to medical school. So this was a lifelong dream for me. And I was really excited. My mom was an ICU nurse growing up, so I've always wanted to be a doctor. So, everybody that goes to medical school, you're psyched, you're finally, this is a lifelong dream, and you struggle in medical school. It is a long, 4 arduous years. And then you get into residency. Until you hit residency, you think in medical school is the hardest thing you did, and then residency is the hardest thing you did. And you struggle for another 3 years. So 7 years of just medical school and residency, you don't even count the 4 years. If you count the 4 years of college, that's 11 years total. And then you finally get out and reality hits. And you find you're not really just, working for your patient, to make your patient better. You're working for an insurance company that really doesn't care. They'll tell you you're not working hard enough. It doesn't matter whether you're seeing 30 patients a day. They'll tell you you're not bringing in enough money. Although they're the ones that determine how much patients are worth. So, they're the ones making the rules, and you'll never beat them. You'll never win. You don't make the rules. So you keep jumping jobs, thinking the next job is going to be better. And it's just, they're all the same. They were all the same. But I don't know how many jobs I had before I finally just gave up. And one day I came home and said I couldn't be a doctor anymore. The last year, the Father's Day, my father said, my daughter cried and said, "Daddy, you're never home." It wasn't long after that, my boss said, after working 12-hour days for 14 months, said I wasn't working hard enough. I needed to work on weekends. And that was at the VA. So I came home that night and told my wife I couldn't be a doctor anymore. And she said, "Well, what are you going to do?" And I said, "Well, I don't know." I said, "But I can't do this."
Wow.
So yeah, so I was whining online, and a doctor named Henry Magalente saw me and said, "You ever heard about direct primary care?" And I'm like, "No," because in an area of 1.5 million people, there are no direct primary care doctors here on the East Coast. So long story short, I Googled it. I said, "Well, why are there no direct primary care docs here if that's such a good thing?" He said, he didn't know. So I found one. The closest one was in Lynchburg, which was about a 2-hour drive from here. So I drove up, saw him, could not believe how easy it was. 30 to 60-minute visits, same day appointments, unlimited visits without co-pays. You get insurance out of the way, and you're just a regular doctor. I was going to spend a whole day with the guy, and then I left at lunch because I said, "This is totally doable." I came home and I set it up.
Wow. And because you're not billing insurance and you don't have all of that overhead, you probably did it did you have any, was it just you to start with, or did you have any staff at all?
It's still just me. Well, my wife's an RN, so she's here with me.
Awesome. I love it. I love it. I love it. I love it. That is great. So tell me the story, because it is really important for our listeners and viewers to hear this, because this is so common for so many doctors. But what did your daughter say to you that one Father's Day that was kind of the straw that broke the camel's back?
She said, "Daddy, you're never home." And she was crying. And she was right. I wasn't ever home. I mean, 12-hour days, I'd be at work at 7, and I wouldn't get home till 7. And I was exhausted.
How did it make you feel as a professional, giving healthcare advice to patients that you only see for 10 or 15 minutes?
Well, so that's why I was at work for 12 hours, because they were crammed an 8-hour day, but I was there for the extra 4 hours, making phone calls, setting up consults, making sure they got their radiology, imaging visits and labs. So, the extra 4 hours a day was making sure they got their care. And unless you're making, it's there the extra 4 hours a day, they're not getting their care. But if you stay the extra 4 hours a day and do it, you're just going to burn yourself out. You're not going to see your kids grow up. You're not going to spend time with your wife. So you choose, and I chose poorly.
And so tell me a little bit about, it sounds like the frustration over and over again with doctors is that you guys go to medical school in residency for, 11, 12 years. And then when you get out, you basically have no autonomy. Is that what you're telling me? You had no autonomy over your own patients or practice whatsoever?
No autonomy. No autonomy. So at the VA, I mean, you're subject to the rules of the VA. Our wait for time for a consult there was probably 3 to 6 months. I think wait time to see me was 3 months. You have to, with insurance companies, you have to ask to get an MRI. Your orders are suggestions. They're not orders. Same with labs.
So I recently,
now
go ahead.
Things are so inexpensive. No, well, now things are so inexpensive. It's just up to me and the patient. I just got to make it affordable for them.
Right. And then they got quicker access too, right? So
Oh yeah, quicker access.
Right. So I was told recently by a hospital that by an employee at a hospital that physicians, they go about their practice day to day. They don't know anything about the insurance companies. They don't know anything about the billing. They don't know anything about the reimbursement issues or the prior authorizations or anything like that. And from what you're telling me, you were dead in the middle of that. So you knew all of that, and it was basically tying your hands. Is that correct?
Correct.
Yeah.
You're basically responsible for the prior auths, and the patients look at you as responsible for the prior authorizations, and whereas the insurance companies are the ones that are holding up the prior authorizations, you can't get a hold of them after 5. So if you stop to do what you're doing to call an insurance company and sit on hold for 30 minutes to wait for them to come to the phone, you're making yourself late for your other patients. They'll walk out. You don't get paid. It's just a horrible system. They don't get care. It's terrible. It's a terrible system. So now I've done, I think, 1 or 2 prior auths here for people. And the pressure's off of me now because I'm getting paid either way. So I don't have to worry about getting paid. I'm just worried about getting care for the patient. And so, they come on the phone with this attitude now, with the prior auths, thinking that, they're trying to put the onus on me. And I tell them, hey, it's not to me. I said, the patient's paying you guys. I said, this is between you and the patient. I told one lady, I said, I don't give a rip if you give this lady her medicine or not. I said, I made the suggestion. I said, this is between you and her. She coughed up the medicine in like 2 seconds.
Well, I think that's one thing. For one thing, if you have power and you have time to educate your patients, a lot of healthcare, from what, contrary to what the popular opinion is, a lot of healthcare is very affordable. Yeah. And that's what you're doing now. You're an advocate for your patient to find better access, faster access, and a lower price. Correct?
Oh yeah, we've got time to shop. So I've done most of the shopping for some of the big ticket items. So my labs. I'll just give you, for instance, ER visit that me and my family had, $761 for 3 or 4 labs. It costs $13.70 here. My patients are continually shocked how cheap the labs are. I'll tell, and some of them, they have insurance on the side. I said, well, if you want to run this through your insurance, you can. I said, I am not billing your insurance for $13.70. And they're always like, no, doc, forget it. Medications, I work through a private pharmacy here, and they get really good deals. They could beat GoodRx half, 3/4 of the time. Some people still insist on using their insurance, but we're working on that. And it's part of the re-education process. Eventually they get tired of spending all that money and fighting with the insurance company, and they come around. And I get it for them a quicker, cheaper way.
Absolutely. So tell us a little bit about what DPC is. I know we've explained on this show before, but everybody's a little bit different. I know in 2018 is when you opened your DPC practice, correct?
It was, I had a soft opening in January 2019 and really opened my doors fully in the summer of 2019. So I've been open a little over a year. I'm not we weren't trained to be businessmen. So I didn't really know what I was doing when I opened up my practice. I had a guy really kind of push me out of the nest in the summer of 2019 and said, get your place open. And I finally did. That was another guy, Ray Courtnoy, down in Florida. He goes, what are you doing? I was like, I don't know. He goes, get in there and get it open. And I did. Direct primary care, it's basically, this is kind of, we all have our different rules, but I give same day, next day, 30 to 60-minute appointments, unlimited visits without a copay. I do take care of minor emergencies and skin procedures. So, for example, I came in on Sunday. I had a lady that sounded like she had pneumonia. She could have gone to an urgent care center, but to save her the urgent care visit, I came in and saw her on Sunday. And I listened to her lungs, made sure she was okay, got her medicine in, and she went home. What else?
You have a member. It's a membership model, correct?
It's a membership model. So kind of like Costco. Costco makes money off its memberships. It doesn't make money off what it sells on the floor, and so everything's so much cheaper on the floor. $75 a month, $150 for the first visit, and basically we do the $150 for the first visit because I found a lot of people would come in, about 1/3 would come in and use me as an urgent care center, and that's not what I was looking for here. And the $150 kind of lets me know people are serious and staying, which is what I want.
And for that monthly fee, they get unlimited access to you. Is that correct?
They can come see me 10 times. People just come in. They'll just sit down and chat. I've had one guy, we would sit in the back and have lunch on the deck.
That's cool.
That was awesome. I haven't had lunch for the last 17 years.
Right.
Yeah, it's been great. Yeah, it's been really good. So I don't bill insurance. If I billed insurance, you wouldn't get any of that. You'd have the average 21-day wait to see me. You'd get 10 minutes with me, and you have a $20 copay every time you walked in the door.
Right.
But
Now,
that's not the kind of doc I want to be.
right. And good for you. And what are some of the other services that you would offer? You saw a patient, you saved her an urgent care visit. Well, I'll ask you some questions about that later.
So I got here.
What else?
I got a nebulizer. My EKG machine just broke, so I got to get another EKG machine. And we don't charge for any of that. The EKGs are free. The nebulizers. I mean, we could charge for the medicine, but it's not even worth it. The medicine, I think the neb's only you probably know a couple bucks,
right?
Maybe. So it's not even worth the time punching that in the computer. So and I don't run a ton of nebs, so they're probably going to expire before I even use them. Yeah, and I'm going to get flu shots. I'm going to give those for like $25 a piece.
And so, Janet, ask Dr. Tinsley about this urgent care visit on Sunday and how that would change a family's life on a Sunday instead of going to urgent care.
Well, I think you asked the question for me.
I did.
So go ahead, doctor.
So, she called and she's got some pretty chronic lung disease. And so she's super high risk, and you've got COVID floating around, and she was missing a couple of things. Missing the fever, but and I heard her coughing, and it was a really wet cough. So she's wanting to call something in, and I'm like, well, there might be a pneumonia here, and I wanted to do a pulse ox on her. So I said, look, let me get dressed, because I just finished a bike ride. So let me get dressed, and I'll see you in the office. I'm only 20 minutes from the office. So I came in here, did a pulse ox. She's fine. Lungs are fine. I didn't hear pneumonia. But she had some other things going on. She didn't even need a nebulizer treatment, so I just treated her and left. But, they would have soaked her at the urgent care center. They probably would have done an x-ray, charged her out the wazoo. They probably would have done a CBC. They probably would have run a COVID test, which would have been a minimum $50, probably $100 or more. I mean, it would have been outrageous.
Well, some of the charges at the hospitals that they charge for a pulse ox, it's unbelievable. It's like highway robbery. And then,
Yeah, I've seen some of the girls. How can they charge for a pulse ox? You just stick the thing on the person's finger.
Right. And here's the thing. I can go down to my local Walgreens and buy one of those machines for $50. And yet they charge like $500 to check your pulse ox. And when you question them about it, they say, well, insurance covers it.
Insurance covers it. Yeah, that's 6 years insurance. Insurance will pay it. I'm like, really? Like, it's outrageous. It's outrageous. Right.
Well, and then this lady's time is worth something as well as the fact that, the worst place in the world is to be sitting in an ER or a urgent clinic with other sick people around you if you already have a condition. And we have several clients that have called us, and I'm like, you probably should go in and be seen, but there's that fear factor. Should I go in? Can I go in? And so the fact that nobody's there, it's you and her, or your wife to help, her exposure to something is reduced. Her experience was better. And then now you have a patient-doctor relationship where you understand each other as to whether something's really critical to be seen or not. And, you're dealing probably with an age group that needs to be encouraged. Okay, maybe this is something we need to see you about rather than you putting off.
Yeah, and that was definitely something that needed to be seen.
So tell us a story about the guy not feeling well. You did an EKG in your office, and he was in AFib. Tell us about the story and how that, you might have saved his life. You saved him lots of time and money. Go ahead and tell us that story.
Money for sure. An AFib, you're at risk for stroke. So, so he just said he wasn't feeling good, and he was been a little tired. So I did an EKG on him, and which I don't charge for, and he was an AFib. But the rate was good. I didn't need to send him to the ER. So, and pulse ox was good, so he was saturating well. Everything else was fine. He was just an AFib. So I called the cardiologist. When can you get him in? They got him in that week. All was right with the world. He had insurance, so he could, run everything else through insurance. I talked with the cardiologist. I started him on Eliquis, the blood thinner. So, I got everything. We got the ball rolling, and saved him a horrendously expensive ER visit, which they probably would have run another EKG and charged, I don't know, whatever they charge for that. And Molly, can you close the door, please?
I'm gonna head out.
Okay, can you close the door? All right, thanks. So yeah, I don't know what his ER bill would have been. It would have been huge.
Yeah, $4,000 or $5,000, I'm sure.
And he would have gotten the cardiologist in like probably weeks.
Yeah. So explain why that is. How come how come you can get him in with a cardiologist specialist faster than the ER could?
Because I've got a relationship with a local cardiologist. This is how we used to do it. We all knew each other. We used to have lunch together, actually. So, but that's gone mostly. So I'm hoping with more DPC docs coming back that we can get that back again. So yeah, I remember that when I first opened up and I called my first specialist, he said he hadn't heard from a family doc in 10 years.
Wow.
Wow.
That is really sad.
I said that's going to change.
So Janet, do you have some questions for Dr. Tinsley?
I'm kind of commenting about this because to me it's tragic that we've severed relationships between providers that have been making, I think, the healthcare in the United States better than other places because we had networking, we could work together, we could help each other out. And I think you hit something on the head when you said this, because I believe this is true, and even in our industry where we work, that we no longer have that networking and working together mentality because, we're all just waiting for who's going to pay us and who's telling us how we're going to work. And so that camaraderie of working together has been severed. And most patients, when something they go through, expect, like if it's a major event, that you're going to have your local doctor be helping you. And that's not the case anymore. A lot of times your clinic doctor doesn't even have privileges at a hospital anymore. They might be there slightly, but most of the time it's a hospitalist. So the connection between the patient and the doctor is severed. The connection between doctors is being severed. So professionals are not
patients.
Right.
And that's how I knew all the specialists. We talked when we were rounding the floors.
Right.
That's all gone. And now that we're all owned by somebody, the Centera ER doctor will refer to the Centera cardiologist. He doesn't even know who works for Centera cardiology. He's just going to refer to Centera cardiology because if he refers to another cardiologist, they're going to burn him.
Yeah, we see that all the time in our community. Yeah. It's very, very sad. And one of the goals of our podcast is to educate and empower individuals that they need to be in charge of their own healthcare. And one of the things that we need to do is just educate them and let them know that these things go on. Just because they're referred to somebody by their local doctor doesn't necessarily mean that that is the best specialist. So that's why it's important to have a good relationship with your doctor. And you can ask them straight up. It's like, look, I want to go to the best cardiologist. I don't want to necessarily go to the cardiologist that's in this system. I want to go to the best one, right? Can you comment on that?
Yeah, ask them, who would you send your brother to? Would you send your brother to this guy?
Right.
If I told these guys, I said, I always tell them, if you were my brother or you were my sister, this is who I would send you to.
Exactly. I mean, that's a great analogy there. Great analogy. So, speaking of, building the network, that's one thing that DPC doctors are really working on. So tell me about, some things that you've helped educate some other doctors to kind of help them come into DPC practice, and even a specialist or urologist lately. Tell us about those stories.
Yeah, so I like to pay it forward, and because I remember how I felt when I was going to quit my lifelong dream of being a doctor. I mean, it was a low point in my life. My daughter hated me because I was never home, and my lifelong dream of being a doctor was in the dumpster. And well, I see them out there on Facebook. I'm not the only one. There's a lot of them out there. So when I see them, I'll throw them a lifeline. I'll tell them, have you ever heard of direct primary care? I'll tell them, brother, set yourself free. Don't stay on the plantation. Get on, get on the Underground Railroad and run.
Yep.
There's light at the end of the tunnel, man. Look at me.
So, and direct primary care is not just for, because most of the direct primary care physicians are probably family practice or internal medicine. Is that correct?
Yeah, and pediatricians. So,
okay.
So this model that wouldn't necessarily work for specialists, but they could do cash. I mean, we have a cash surgery center in Charlottesville here. There's a famous one down in Texas. I think they started it all, from what I hear. They were the first I ever heard of.
Surgery Center of Oklahoma. In Oklahoma.
That's I remember reading about them, I don't know, years ago.
Do you mind for our listeners and viewers giving us the name of the surgery center that's local to you that does cash procedures?
Pull it up. They're out in Charlottesville.
Because we really like to promote those. We want our viewers and listeners to understand there's options out there, and that they don't, sometimes just traveling a little bit can save them thousands and thousands of dollars.
These guys are maybe 2.5 hours from me. So I haven't had to send anybody to them yet, but they're definitely in my list of consults. So there's another one in Wake Forest, which isn't far from here. Wake Forest, North Carolina, Forsyth Surgical Center. There's one. So they do some different surgeries that the ones in Charlottesville don't do. And then there are the ones in Charlottesville. It's Monticello Surgery Center.
Monticello Surgery Center. Perfect.
Yeah, they're a little bit closer.
Uh-huh.
And that's probably where I would start. But if they didn't do what I was looking for, I would go down to the one in down in North Carolina.
Awesome. I love that you know those options for your patients, and you know how to send them to, get them a discount on labs or X-ray or surgeries, and get them the best service. That's what's. I think one of the, Dr. Keith Smith, the CEO of the Surgery Center of Oklahoma, he said one time to me that when a doctor takes the Hippocratic Oath, part of that oath is to do no harm, correct?
Right.
And this is starting to get out there a little more now, because I've heard other doctors talk about this. Part of that harm is financial harm. And when doctors send patients to a place that they know is going to overcharge them, whether it be a local hospital or a local clinic or some kind of local imaging center, where they're going to charge them $3,000 for an MRI, and they know that somewhere else they can get it for $400, you could argue that that's doing harm to the patient. Do you have any comment on that?
Harm to the patient, doing harm to their families, taking money from their kids, stealing.
Absolutely. Yeah, I totally agree. Yeah.
So I'll give you a good example of saving money. There's a cash gastroenterologist here. So colonoscopy can run $2,500 to $3,000. I'm getting mine done for $785 plus $50 per biopsy.
I love it. See, that's what I love about free markets. It's so Janet, and I wrote about it in my book. Janet has a wonderful story. She's got a history of colon cancer in her family, and there's been multiple family members that have died in their 40s. So she started getting colonoscopies in her 40s.
Yeah.
And the last time we had it was I'm sorry, not the last time, but the time before last. It was the last time when we had typical traditional insurance and things were going to be covered under Obamacare.
Right.
So we're like, okay, let's get this procedure covered, Janet, and then we'll go to our health sharing ministry.
Right.
So it was covered all right. We went to our local hospital, and they had no idea what the procedure was going to cost. The procedure was $5,000, and of course it was covered, and our copay was $3,000.
Yeah, exactly.
It was covered. It was covered.
Exactly.
And the service was horrible. Janet stayed there for 12 hours. They kept putting her off and off and off. And a hospital is not the best place to get those things done anyway, probably. For that reason, that's not what they specialize in. Fast forward 5 years later, we go to a clinic that specializes in it. It's about an hour and a half away. We drive to that clinic, and We are back home by 10 o'clock in the morning, and we paid $1,100 cash out the door. Awesome service. It was amazing. I mean, it was unbelievable.
Well, I'll tell you, well, this guy, can I just tell you his name? Dr. Keith Berger down there in Virginia Beach. So Virginia Beach, for me, is a little bit of a drive. It's probably going to be about an hour, maybe a little longer because we have tunnels under the rivers here with traffic. Depends on how I hit the traffic. But when you consider I'm saving, $1,500, maybe $2,000, it's worth the drive.
For sure.
It's true. And then I also knew what my results he sent the results off too to confirm it, but I knew what I had my results before I left the place. I didn't have to pay for another consult visit. I got my results sent to me, and if there was any questions I could, but it was all up front. There was no surprises. And
right.
Honestly, you go through that procedure and then you're told, well, our surgeon has to take care of this, or our surgeon you might have to come back tomorrow. And I'm like, no, we're not taking days off from work and coming back tomorrow. This is not how we take care of clients. For one, I know we are patients, but let's be honest. If that was them, how would they like that type of treatment? And
exactly.
I feel like it also comes down to a little bit of integrity too, because those clients have taken a day off from work or taken a whole day out of their life to do this procedure, and then we're going to say, well, this is more important than that. So my experience the last time around, I will never go back. And it's not that I don't like the people that helped me. It's just that as a consumer of healthcare, I'm not repeating that horrible experience when I have somebody that's out there that I can pay upfront, who knows what, they see lots of clients, they're legitimate, they're fair, and the whole experience is better.
Right. Well, you got to look at it, with free market, you're service oriented. You rely on return business. You rely on them sending you people. You screw something up, word gets out, nobody's coming to see you. These other guys, they don't care. They don't care. They have people lying. They have people feeding them constantly. If they're Centera GI, I say Centera a lot because Centera is one of the big players here. They have all the Centera family doctors feeding them, so it doesn't matter. So it doesn't matter if they piss off a couple of patients because they'll have all the other Centera family doctors sending people to them. But yeah, so I called my guys that I've had 3 EGDs with, scopes. I had my last colonoscopy with them. I've been sending them patients for 15 years, and I couldn't give them to give me a straight answer how much my colonoscopy was going to cost. They said, well, you have to call billing. And of course, billing puts me on hold for like 30, 45 minutes. And they give me this big runaround. It's going to cost, I think, $2,000 or plus for the colonoscopy. Then the anesthesiologist is separate. Mm-hmm. And then they don't know how much the path is going to cost. So I called the pathology department, and they will definitely not give you a straight answer of how much the pathology is going to cost. And their specimens, they say, are probably $150 a piece, which I know darn well they're only $50 a piece because that's what Berger's charging across the river.
Well, and here's my suggestions to individuals or clients or consumers of healthcare. When they call a place and they can't give them a price, don't go there.
Right.
And if they can't give them a straight price, then don't go there. And if they say, well, it depends on how the doctor codes it, and it depends on this, that, and the other. Yeah.
That's the first excuse they gave me. Depends on how it's coded. I said, no, it doesn't. I said, it does not depend on, I said, I'm a family physician. I said, it does not depend on how it's coded. And that's when they went, wait a minute, I'll be right back.
Right. And it does seem that these systems we're trying to navigate, they don't like having educated consumers. So when you and I are talking about these things, those hospitals, those healthcare entities, they don't like these things exposed. They want non-transparency. They can hide behind that. And that's what I don't want to happen. I want to expose it for what it is. I want to make sure consumers get the best care at the best price they can.
Yeah, well, all my patients, I can't keep them all out of the ER. I can only see and treat about 80%. I can only treat about 80% of the stuff I see. Some people end up in the ER regardless. But I tell them bring their bills in, and I'll price what things should cost on the bill to bring it down.
That's awesome.
Yeah.
Good for you. Good for you. So one thing about when you talk about free market, and you've got skin in the game when you don't want to make a patient upset, right?
Right.
And you were talking about this Cetera. One of the reasons that they don't worry about it is because if you think about it, they're the patient, and I talked about this last week on our podcast, the patient is not their customer. The insurance company is, because they're paying the bill. So they don't care because the insurance company, they signed some kind of monopoly agreement with that insurance company. Right. They're the only place those patients can go. The doctors can treat them as horribly as they want. And I'm generalizing here. I am not personalizing it.
Right. Because they're, you go to medical school to help people, but they're so burned out. They've got a mountain of work and they got 5 minutes to do it, and you have to triage. You have to spend more time with the sickest person. If you're not as sick as that person, you're not going to get as much time. I mean, time can either be created or destroyed, and that's just the facts.
Yeah,
and
that's right.
Box doctors into that. They put doctors in that box. So, but you're right about. But what's funny about hospitals working for the insurance company is that the insurance companies pay whatever the hospitals ask.
Right. Well, they do have a discount. They overcharge. They inflate the price, and then they write off part of it. Is that correct?
Then they write it off, and then we pay what's written off.
Exactly. That's exactly right. They're not really writing it off. They're just charging. They overcharge in the first place, and then unfortunately, those of us that don't have traditional insurance, we're the ones that get overcharged, and we pay that. It's called cost shifting. It's that simple, right?
Well, it's unfortunate that we've came to this place, because I guess I was blessed growing up in a community where the local doctor was able to see his clients. He didn't have to ask you, a whole checklist of questions on his computer as to what was going to get him paid,
Right.
I mean, the ridiculousness of, what those questions are, whether they're important to whether the care of the patient is really being taken care of, right? And the fact that, even as a teenager, if I needed my physical, he gave the physical. If I needed to have, an x-ray, whatever. I mean, it was all, we knew who he was. He knew who his patients were. And we didn't have this craziness of, well, gosh, if I go in, I'm going to be broke. I'm going to have to sell my firstborn's leg or body part in order to, pay for it. And that, to me, has just kind of made healthcare almost, I guess I'm kind of lost for words, but
if it's not affordable, it's not accessible.
Right. Exactly. Right. And so now we have people that, need to have needs met, but they can't even talk to their doctor when they go in.
Right.
Because they only get maybe 1 or 2 or 3 questions in 10 minutes.
Right. If that.
Right.
Mm-hmm.
And so then we slap them with a big bill and say, there you go. You're out the door.
Yeah, bye. See ya. I'll see you back in 2 weeks.
Right. So
my notes aren't 5 pages. And my notes are maybe a half a page, 3/4 of a page. My physicals will run over a page, but that's because they're complete physicals head to toe.
Yeah. And you have a relationship with that patient. And that's you're not just checking off boxes to get paid for things. So, when you read those notes again, if you need to follow up with them, you read those notes again and it comes back to mind, right?
Yeah, it's pertinent information. And also, since I know my patients well, I can do a lot of stuff over the phone. So I know, like the lady that had a cough on Sunday, I knew I needed to see her. But if somebody else has a cough, I don't necessarily need to see them.
Right.
Right. Yeah. So, do you think this is a transient phenomenon, this growth of direct primary care and physicians getting out of the system type medicine and going into, more of a free market type? Do you think this is a transient thing, or do you think this is a future?
I think if nothing changes, I think it's the future, because we're growing at an exponential growth rate right now. But I think right now insurance companies don't necessarily see us as a threat, but they're the ones with the big lobbyists. I mean, they could pass some laws and squash us, because right now they're stopping us from using HSAs, health savings accounts. They have the lobbyists and they have Congress, so I mean they could outlaw us in a nanosecond.
I want to say, maybe you can help me with this. I want to say there's a bill in Congress right now to be able to use HSA accounts for DPC monthly reimbursement, and I think it passed, but I'm not sure about that. Is that true? Do you know?
No, I don't think it's passed yet. I think it's like in committee.
Yeah. Okay.
But they also wanted to restrict how much I can make.
Interesting. Yeah. And you
my salary.
Yeah.
You know who put that on there?
Yeah, of course. Yeah. Follow the money.
So if I take HSA money, I'm gonna have to take a cap. So I probably won't take. Well, right now I'd be okay, but I'm probably not going to take it just on principle, because I don't believe that the government should be telling me how much I should charge.
I love it. And that's what I love about doctors that go into DPC is you guys, not that you don't want to make a living, and I'm a capitalist. I got nothing wrong with somebody making a living and making a good living, but you guys really are basing your decision on principle. And there's a lot of doctors that get stuck in the system, and I don't think they necessarily like the principles they're living by, but they get stuck in the system. And I really, really am glad that there are doctors out there like you to get out of the system and to help others get out of the system.
Yeah, and that's part of the problem with doing what I do is if a doc left, we have such horrible non-competes that you pretty much have to leave the area. I mean, I was with Tidewater Physicians Multi-Specialty Group a long time ago, and my non-compete was 45 miles from any of their offices, and they had offices all the way up in a town called West Point, which is about a 45-minute drive west, and then way down in Virginia Beach, which is southeast of here, about an hour's drive. So I pretty much would have had to leave southeast Virginia.
Right.
But I found a job that didn't compete with that. So basically I left community care and ran out my non-compete. But so docs are stuck. If they want to do what I do, they have to go to a strange town where nobody knows and start all over, which makes doing something like this really hard. Like Riverside, another big hospital group here, they have a 60-mile non-compete. Centera, I'm not sure what their non-compete is, but I'm sure it's just punitive. They all are.
And I want to say that there's some legislation involved I've been following too with some of the DPCs, that there's legislation about trying to do some of those non-competes. Is that true?
With the DPC?
Well, the DPCs, there's some lobbying about trying to get rid of some of these non-competes, that they're just too over-encompassing.
Right. So when I first got out of residency, they had a rule of thumb. The rule of thumb was every mile you moved away from your practice, you lost 10 patients. So the non-compete, as a general rule, was 5 miles. You had to move at least 5 miles, so you lose at least half your patients. And that's pretty much what all the non-competes were. But about 2 or 3 years after I got out of residency, I started seeing the bigger non-competes. The first one I saw was 10 miles, and I refused to sign that contract because that was in Richmond, and that was with HCA. And I refused to sign it because 10 miles was the diameter of the city of Richmond, which basically I would have had to leave Richmond. So I was told them to stuff it, and I wasn't going to sign the contract. I went with somebody else, which was that was the beginning of my job jumping career.
Well, I guess, please educate, maybe some of the doctors that are out there thinking about DPC, but I guess one of the things is that you can decide not to sign a non-compete. That's probably your best option. Is that correct?
Yeah, you can tell them you don't want the non-compete in the contract, but then they can also say, well, we don't want you.
Yeah.
I've talked to some docs where they've taken the non-compete out, but I've also talked to some docs where they didn't get the job.
Right. So tell us, because your services are so affordable and people are so used to hearing how expensive it is to go to the doctor and how expensive healthcare services are, you have actually been asked by people, are you a real doctor?
Yeah, and that was one of the hardest things about opening this up. People thought I was people thought I wasn't a doc. They weren't coming in. So I actually put it on my business card that I am board certified and state licensed. What is the name of that group? There's a company that has concierge doctors here. I can't remember the name, but they're a national company, and they charge $150 a month, and I'm $75 a month. So I'm basically cost the same as half a cup of coffee a day and way less than half a pack of cigarettes a day.
Right.
So people spend $75 a month, and they asked. I remember I was on Facebook, and they said, "Don't talk to this guy. He's not even a real doctor." I said, "I am a real doctor." I said, "You can Google my license online. I've never been sued." I said, "I am a real doctor." I said, "Here's my NPI." And I put it on.
Right. So you were able to get out of the system. There's a lot of doctors that don't. And, in our pre-show call, you kind of said it was a Stockholm syndrome. Can you elaborate on that, about these physicians that are stuck in the system?
Well, yeah, most of these guys, I was like that. So you don't think, since all you've ever done is work within the system, and there's not a lot of direct primary care docs out there now. We're getting there. I think Dallas-Fort Worth, there's 35 docs, DPC docs. But you don't think that there's any other way to do it. And you can't see that they'll think, I've seen them think that this is too hard. They have a lot of reasons not to do it. And this is hard to do. If this was easy to do, we'd all be doing it. There's a risk. There's a risk that you'll fail. So you have to open up. You have to start your own business. You have to run your own business. I was doing some of the financial stuff before I called you guys, and that's my least favorite thing to do. I want to be a doctor. I didn't want to run a business, but that's what you got to do if you're going to do this. So they have all kinds of reasons not to do this. But they're excuses. And so the only other option is to stay in and work for the insurance companies. But that's their comfort level. Their comfort level is being a slave to insurance companies.
Well, I can say that for Sean and I, that was quite a blessing to walk away from being stuck to the insurance. I would much rather deal with clients and patients any day of the week than having to try to finagle a way for an insurance company to pay for a service that had already been
given. Yeah. He who holds the money holds the power.
Right.
Yeah, let me tell you a liberating story. When we got out of insurance, the last insurance that we stopped billing was Washington State Medicaid. And, it's everybody's fear that, when they say when any insurance company is going to take back money, it's just everybody's fear and when are they going to take the money back and all that. So I was on the phone negotiating with Washington State Medicaid, and they were going to take back money from, 4 or 5 years, something like that.
They overpaid on gloves. And
they overpaid, and that was oxygen, I believe.
No.
Okay. And then anyway, it was really liberating when they called me, and I got to negotiate with them, and I think it was like $12,000. And I told them, I said, look, I'll give you $4,000. And they said, well, that's ridiculous. They said, we'll just take it out of your next check. And I'm like, guess what? I don't get any more checks. So, yeah.
Right?
It was, and so they had to get, it was beautiful. I loved it. And I love telling this story to doctors and pharmacists, anybody trying to get out of the system, because you're always so fearful of those people. But I was in charge, and I told them, I said, look, you either, and they got their attorney on the phone, and the attorney was negotiating with me, and she said, I can't believe that I'm doing this. And I said, yeah, it was beautiful. It was beautiful. She says, I said, I will write you a $4,000 check, or if you want me to pay that $12,000, I will pay $100 a month for the next however many years, and I might go out of business next month, and you might not get anything. She goes, well, if I sent you a release right now, would you sign it and say you'd write me a check? I said, yep. Anyway, it was so liberating. And
That's so
that,
awesome.
right. And that to me, it's not about, Janet and I do well in our pharmacy and we don't bill insurance. It's not about, even though we are thriving financially and it's more than just survival, to me, it's about liberty. It's about me. Yes, it's freedom from the insurance companies. It's between us and the patient, and we love what we do. And a lot of pharmacists cannot say that.
Yeah, I guarantee you they're not happy. I mean, I've talked with, I remember, 15 years ago, I used to love chatting with pharmacists, but now you talk to them and they're miserable. They're miserable. They're not happy at all. I mean, most of the pharmacists I know from the mom and pop shops are gone. I really miss those guys, but it's funny. I had a guy, a drug rep in here, and he goes, Dr. Tinsley, if your patient's been coming in, this is when COVID just started. I'm like, nah. I said, they're all home scared. They're, nobody's coming in. And he goes, well, aren't you worried? I said, no, I get paid every month. I said, I'm getting new patients every month. I said, my business is growing.
Right. Right. Well, and, one of the things that was beautiful about DPC, is you guys already did video conference and other ways to use technology to see your patients. And when the COVID thing happened, you see these offices bragging about their telehealth stuff. But the reality of it is you guys have been doing it for years.
We've always done it. Yeah. Nothing's changed. There's somebody asked, I know I was talking about it. They were like, oh, we're doing something. I'm like, yeah, I've always done that.
right.
Yeah, I was talking with a guy on Facebook last night about that. He's trying to show me all this new stuff. Like there was this telehealth thing that we'll order labs. And I said, dude, I already do that. I said, yeah, but they order labs. I said, I order labs for people. Yeah.
But the other thing I think as a patient, I want to go to a provider who's happy, right? I want to go to somebody who's really excited about their job and loves what they're doing, because that's where I'm going to get the best care. I'm going to go to somebody who is happy with their practice in their life, and that's the person who's going to identify problems with me and like to take care of me, because it's not a drag to go to work. It's not taking him away from his life and family. He's super excited to be there. And so that in itself, to me, is a huge motivation to any of those providers out there that haven't taken the leap. If you want to live again, get outside of that box and start running towards a DPC model.
It's like The Hobbit. You have to take that first step out the door. Yep. That's the worst one.
Yep.
That's so true. So, Janet, do you have any final questions for Dr. Tinsley as we wrap this up?
I'll just say it for the docs
yes.
today. I had 3 patients today. All 3 of them called. They got same-day visits. I spent all the time they wanted with them. They were out the door. All of them are happy. Another one called. You want to call it telehealth? You can. Actually, she didn't call. She texted. And then she sent me a picture of the cellulitis on her arm. And I called her antibiotics in. So, I mean, we aren't doing anything different. This is what we used to do probably 20 years ago, except for the picture on the phone.
Yeah, right. I love it. And I can tell you love what you do and you have a passion for what you do. And I'm sure, your patients see that. And that is just awesome. I love to see doctors like yourself that will step outside the box, because we need doctors for sure. And we need doctors that are willing to, buck the system a little bit, because the system needs change for sure.
Yeah. And I make house calls again.
I love it. Right.
Yeah.
So in the last couple minutes, Dr. Tinsley, to wrap up our show today, what are your parting words for the show, and how can people find out more about you?
My Facebook page or my website's on the bottom of the screen there, lighthousdpc.com. If you want to call, you're welcome to call 757-586-3050. I answer any questions. I've had people that aren't sure about signing up. I don't charge for people that just want to come in and chat and take a look around the office. I've had a lot of people do that. I guess they want to see if I'm a real doctor.
Good for them.
But yeah, I don't charge for people that just want to poke their head in the door, take a look around. I mean, that's no problem. It's very relaxed here. There's nobody in the waiting room. It just doesn't work out that way. And I love what I do again. Yeah,
Awesome.
I'd love to have all my colleagues say the same thing. So if there are any doctors out there watching this, you can please give me a call and I'll point you in the right direction. There's a whole Facebook page full of docs like me that'll help you out as well, because they help me out.
Awesome. We love it. We love it. So, well, thank you for listening and tuning in today. As always, I am streaming live on my personal Facebook page and the Moses Lake Professional Pharmacy YouTube site. You can also find us on all the major podcast forums. We should be there. This episode should be there tomorrow. iTunes, SoundCloud, Google Play, all those, iHeartRadio, all those, your favorite podcast forums. So subscribe to our YouTube channel. Subscribe and comment, please. We're getting our YouTube channel growing there, and we love having the engagement. If you guys would like to see a certain topic, please let us know. And Thursday, stay tuned, because we will have Cheryl. She is a personal trainer, personal health coach, and she has a gym over in Western Washington, and she can't open the gym, and it's really financially hurting her. So we're going to talk about how the COVID restrictions have really hurt gym owners. And so don't miss that. We'll be streaming that live Thursday at 8 to 9 a.m. Pacific Standard Time. So stay tuned for that. You've been listening to Health Solutions with Sean and Janet Needham. Thank you for tuning in.